an initiative of the Orange County Coalition of Community Clinics that is funded by CalOptima to increase access to medication-assisted treatment in Orange County. And so we've had the pleasure of having Dr. Mario San Bartolome, commonly known as Dr. Mario, as the medical director of the MAC Connect program, in addition to the many hats he wears. And he is joined today by Dr. Nichole Quick, known to many of you, obviously. And Dr. Quick is now the medical director of KCS Services Community Clinic. So I would like to just start by thanking both of them for attending today. I'm going to allow them to introduce themselves. We'll be asking some questions in an interview style format, and then take time at the end for questions. So please let us know or put your question in the chat. Dr. Mario.
Thank you so much. So it's certainly a pleasure to be here. And, as mentioned by Jewel, I wear a lot of different hats. I guess maybe the most relevant of some of the experience that I have has to do with the fact that I've pretty much been a medical director at every level of care in the continuum of addiction treatment. So residential treatment, IOPs, establishing hospital-based detox units for withdrawal management, as well as the outpatient, which will be a lot of what we'll be discussing really here is a lot of what can be done as well in the outpatient setting. I'm, along with Dr. Quick here, we're both actually quite involved in a lot of the medical societies and advocacy organizations that really are looking to advocate and serve families and those individuals that are affected by addiction. So, I'm really happy to be here. Hand it off to Dr. Quick.
Hi, everyone. Thank you so much for joining us this afternoon. Nice to see some familiar names, both from both county and from the private sector on the list here today. And my background, both in recent times and the past, is both in private sector addiction medicine as well as public health addiction medicine and just public health in general. So happy to provide that perspective tonight, along with all of the wealth of knowledge that Dr. Mario is going to present. And once again, just a thank you for all of you joining us tonight to discuss this important topic. And I look forward to an active discussion. We really want to get audience participation in this. So glad that you are all here.
I thought one of the first things we would do is really kind of level set and talk to you about what's the scope of the problem in terms of substance use disorder that we're seeing both in the country as well as in California and Orange County specifically.
So I'll start out with this, and those of you that have heard me talk before, I could talk for an entire hour on this, but I'm just going to give just a really, I'd say, brief overview of kind of what we're seeing and what we're talking about. So, this is the current wave of overdose deaths, as well as just opiate use disorder. It's not the first wave we've experienced in this country. And if you've heard anybody talk or you've done research on this, there often are referred to as multiple waves of this opioid crisis. Probably familiar to a lot of you as well, that a lot of this started with an increase in prescribing of opioids in medical practice. Not going to go too in depth into that, but just important to note that we did see, before a rise in heroin, we did see a rise in prescription opioids. That was followed by a rise in heroin. And then more recently, and very concerning to all of us, and we'll probably talk about that in various aspects tonight, is a rise in synthetic, particularly fentanyl and fentanyl derivatives. And that is concerning because fentanyl is extraordinarily potent, and many individuals can overdose and die very early in their use of fentanyl. So a little bit more of that to come. But I want to start with some statistics about kind of what we're seeing right now at this point in time with opioid overdose deaths. And I just pulled some recent data so that I'm going to say recent data, but any data, there's always a sort of a reporting delay. But between November of 2020 and 21, so right during the COVID pandemic, more than 100,000 Americans died of overdose. And that was an increase of 16% sort of throughout the nation over that previous year. Specific to Orange County, if any of you are familiar with some of our databases, the California Department of Public Health overdose dashboard is a super useful tool that you can go to if you want to kind of explore what the opioid crisis looks like in California. You can get down all to the individual county level. And right now in Orange County, I took the last entire year that has reporting data available, there were 503 deaths, and this is 100% increase from 2018. So for a while, we all felt quite good in public health. I shouldn't say quite good. We were hopeful that we were turning sort of the direction in overdose, but with the challenges of the COVID pandemic, both on access to care as well as just stress to individuals, we've actually seen that trend vastly going the wrong direction. You can look at some of the graphs and there's almost a 90-degree angle of increase in overdose deaths. The other metric that I want to point out that's very important to our discussion today is the use of medication-assisted treatment, largely buprenorphine. So we track that as a metric in public health to look at how we're doing responding to the problem of opioid use disorder and how well we're doing with treatment. In Orange County, since 2018, we've actually continued to see a decrease, and it's a decrease in the range of greater than 20% reduction in the amount of buprenorphine we're prescribing in the county since 2018. So that metric's going the wrong way, as are overdose deaths. Want to also point something out in reference to the COVID pandemic. For the first half of 2021, which is what the study period had access to, first of all, this was across the whole country, not just Orange County, but more individuals died from opioid overdose than from COVID. And this is not to minimize the effect of COVID, because both have had a huge effect on life expectancy overall. But just to point out that while we've had this decrease in life expectancy and a huge amount of deaths from COVID, we are seeing the same thing with opioid overdose right now. So my point in all of this is just to point out that this is a very important problem that we need to tackle both on the individual level as well as public health.
I'll add a little bit to that story as well. Is, one of the issues that has, makes this different, this wave that, or these waves that Dr. Quick has been mentioning, and we can actually go back to the waves back to the 1800s when the first opium dens existed, and we started passing laws. In fact, some of the structure we have around laws like pharmacy boards and the kind of prescription system, all that came from a desire to regulate opium and cocaine. And so it's interesting how we have these patterns of things. And so there's always a supply side and a demand side. The supply side is, let's keep all the drugs out. So that's the DEA discussion, the justice system discussion, the people that are trying to keep the supply of things like fentanyl and other substances out of the country. And then there's the demand side, which has to do with a lot of public health, types of approaches that have to do with education, that has to do with access to treatment, harm reduction, and prevention. So there are a lot of things at work as we move towards the different waves. And it was already mentioned the wave around prescription drugs. Well, for the last decade, prescription drug the number has been dropping, and it's an inverse relationship with what's happening with overdoses. So I was on a presentation yesterday, and there was somebody that got on and asked a question, very angry. Why aren't we putting all these doctors in jail? And I said, well, we should put the doctors in jail that are the ones that have pill mills and that kind of thing that are hurting people. But from the standpoint of public health, that problem is kind of gone down, and we have this other layer that we have to understand better. So then after that, when we kind of began to clamp down, people moved to illicit substances like heroin. And then the next wave that followed is fentanyl, synthetic fentanyl. But let's be clear, it's not fentanyl that's being prescribed. Fentanyl is a medication that can be used in a hospital setting, for example, in an emergency room. It can be used in a surgical suite, and it's often used for people with very severe pain and sometimes end-of-life type pain as a patch. We call it a duragesic patch. So it's actually something that's usable. And as we all know, chemicals don't have personalities. They're not like good and bad. In fact, they can be very useful as tools. However, they can also have other problems. So what we're seeing is that almost all of this fentanyl is coming from China, and it's being produced illicitly. And it's a powder. So what happens is, what we're seeing is that people are dying from this last part of this way, besides dying from initially, again, that heroin and then the fentanyl. And then now what we're seeing is the combination of fentanyl with stimulants. And that is driving a lot of what the deaths are. So imagine somebody that uses, say, methamphetamine, and they get, what they think is meth they bought, and they smoke it, and lo and behold, it has fentanyl in it, and you only need a couple of grains of sand to die. And they're what we call opioid naive. In other words, their body's not set up to have the tolerance that somebody that uses opioids would have. So that it could be a one and done. So we're in this weird place where you can not have addiction and die from the disease itself, from the exposure. And I would almost call it a poisoning, really, at that point. And then they can also you can also die where opioids aren't even involved, but you thought they were. Maybe you bought some Percocets and you thought you were using some Percocets, but no. And a lot of my patients, they're surprised when I tell them, "Hey, you came out positive for fentanyl." So fentanyl, what are you talking about? I don't use fentanyl. And so it's one of those things that now, it's worth mentioning that fentanyl with stimulants and this phenomenon it's a unique one. And so there's, again, this supply side and demand side. And part of what we're here to discuss is not so much the supply side, from where, we're not involved with the DEA and, closing borders or any of that kind of stuff. But we certainly want to have education and for people to know that along this continuum of this treatment that, might start with, early education and prevention of anyone ever using it all, to, if they are using a substance, that they can harm reduce. And that they can not have other side effects that they can have, because the use of opioids, besides dying, and I'll be honest with you, it's a tip of the iceberg thing. Dying is one consequence, but there's a whole mountain that's multiple times larger of what we would call morbidity. So all the other things that happen with the overdoses that are non-reported, that are non-fatal, hepatitis C, HIV, violence of all different sorts. There's just a lot to unpack from the standpoint of the effects. And in Orange County, we've had this major. We've had a real major increase. So very important that we discuss this and we put it in context so people understand, where is it coming from? How are people being affected? How is this different from what we've experienced before? It's worthwhile to also mention a last bit. I'm not going to go into detail, but in the background, there's this little thing called benzodiazepines. And that came around, you might have heard of chemicals like Xanax or alprazolam, one of the most commonly used ones, but also others, that when you combine them with an opioid, it makes the rate and the likelihood of dying skyrocket, versus if you just take opioids or if you just take benzodiazepines. It's not, you have to work at it to actually die. But you combine them, and the game changes at that point. So all of this information is very important to understand the context of what Dr. Quick is actually mentioning. So important.
Thank you, both of you. The next question we really want to talk about is, what is medication-assisted treatment? So I am sure that we have a variety of individuals on the call today who may or may not be familiar with MAT. And then if you could talk about who it's useful for, that would be helpful.
Sure, I'll attack this question here a little bit. And so, look, there's a lot of opinions about what medication-assisted treatment is. If you go out to the boards on the internet and you start looking around, you have all sorts of opinions. So let me tell you what it means to me as an addiction medicine specialist. Medication-assisted treatment, it's kind of an unfortunate term because, for example, we don't call insulin medication-assisted treatment for diabetes. It actually creates another silo. I don't like it because, addiction should be part, and the treatment of addiction should be treated just like if it were any other disease that we needed to give attention to and the respect to, not a silo, a separation of sorts. But nevertheless, it exists. So you have to know. So MAT, medication-assisted treatment, or medication for addiction treatment, really revolves around the use of specific chemicals that are FDA approved, primarily revolving around opioid use disorder, alcohol use disorder, and nicotine use disorder. Those are the three areas where we have medications that are specifically targeted and FDA approved to be able to improve the harm from the disease, and to improve abstinence, and to improve any sort of an outcome that can, we can attribute as what we would call a co-occurring or comorbid condition. So none of these are like a fix. Just like in the example of diabetes, we don't give insulin to somebody that comes in and learns that they have diabetes and then they're fixed, right? They're not like they walk out and they're like, gosh, that insulin was great, man. My diabetes is gone. It's not the case. The insulin might be used to decrease the likelihood of having kidney damage, eye damage, and a lot of other things from uncontrolled diabetes. Well, guess what? In a chronic disease like addiction, we have the very same things that go in parallel. So whereas a lot of, and it's important, I would say, that we have kind of different camps that have developed over time. And I think the camps are getting smaller, which is good. It means kind of people are kind of lumping together some, but we've had in the past these camps of like a abstinence only, or a medication only, or, must be hospitalized, or all of these things. And kind of, I think that we're reaching a point now where we're becoming a little bit more rational and using evidence-based type of approaches. And that just means we're getting information and we're trying to see what works and looking at the research. And sometimes we have to have different endpoints. So in the case of, say, a pneumonia, if I wanted to study an antibiotic and give somebody an antibiotic to fix pneumonia, I generally probably, my endpoint would not be, let me just hope he breathes better. My endpoint would want to be, I want to cure the pneumonia. That's kind of like how we use what we do for antibiotics in general, okay? But that's different in the case of medication-assisted treatment and in addiction, because it's a chronic disease. It's not acute. There can be acute issues that come about that we have to deal with, like overdoses, like intoxication, the effects of intoxication when we deal with addiction. But there's also the fact that it's a chronic illness. It affects some now notable areas of the brain that involve the reward pathways of the brain. It involves a neurotransmitter called dopamine. I mean, we can take pictures of it now, actually, in the brain. And we know that it just doesn't go away, even if somebody just has some abstinence period in between. And you know what? For those that maybe are familiar with 12-step, same thing, right? If somebody's doing well and they've been in recovery for several years and been working their program and showing up and kind of evolving in their own recovery, they're not done, right? It's just that they still have to be mindful of their situation and kind of their risks. So in particular, the medications that we use in medication-assisted treatment for opioids are buprenorphine, methadone, and naltrexone. Those are the ones that fall in what we call medication-assisted treatment. Now, some of you might be familiar with the commercial names like Suboxone. That's just a brand name, right? Like Levi's or Kleenex. But the actual chemical is buprenorphine. And it can come in just buprenorphine or buprenorphine naloxone. And buprenorphine naloxone, the reason we add naloxone, which is technically the same chemical that we use called Narcan, the brand Narcan. And that's just a reversing agent. But when you use it under the tongue, which is the way we normally dose this medication for when we're dealing with addiction, because it is a version of an opioid. Buprenorphine is what we call a partial agonist at the same receptor, the mu receptor, that has to do with pain, actually, in the opioid family. And what it does, it acts in some ways like a regular old opioid. And then also can actually have some effects that make it almost act like the opposite of an opioid. And so there's some things to know about that when we use medications like buprenorphine to start them. And we call that process an induction. So some of these things I only bring up only because the medication is used to basically stabilize all the side effects from withdrawal. So when it's almost a magical medication as far as that part of it, okay? It's obviously, like I said, it is not a fix or a cure for addiction. But it does stabilize. So someone can go, for anybody that has seen, has known, has been addicted to anything, you can probably attest to the fact that there's this thing called withdrawal that really sucks. And it can range from, hey, this is uncomfortable, I'm feeling a little anxious, to I want to die. And your nervous system actually sometimes doesn't know the difference actually of whether it is kind of dying or not. because it's just going off and it's having this kind of fight or flight reaction. And in some substances, like in the case of alcohol or benzodiazepines, you can actually die from the withdrawal syndrome. Not so much from opioids, although there can be some serious effects if with this, when there's other things attached to it. This medication completely resolves it in hours, the withdrawal. And then it stabilizes somebody. It's very long acting. It also is very strong when it attaches to the receptors, so it actually can block other opioids when it's properly dosed. And so many people do well. Stabilize somebody so that they can engage in treatment. They can engage with counseling. These medications are meant to be used with counseling, with addressing mental health issues, with addressing medical issues, and with mutual support, which is all the peer support that happens, like a 12-step or a smart recovery or celebrate recovery. All of these, wonderful mutual support type of options that we have out there. So just to kind of wrap this up, and we'll save this for maybe some of the questions. MAT is really these medications, and I mentioned buprenorphine as one of the main ones because it's outpatient. To do methadone, you've heard of methadone. You have to go to an opioid treatment program, which can be very effective for some people. More or less, it's kind of reserved for people that really need lots of structure. And it's federally regulated, so it can't be something just people can prescribe. There's a few other details to methadone. You have to go kind of usually every day, although the model is beginning to change some. And both of them can be used during pregnancy as well. So it's something that can be used if somebody is dependent during pregnancy. And if somebody has questions about that, I'm happy to discuss that as well. The last one is naltrexone, which is the opposite of kind of these. This is antagonist, similar. It's the sister to naloxone. And what it does is it acts as a blocker. So it's not a narcotic. It's not an opioid. It is not scheduled. In other words, it is not something that the DEA controls. You cannot get addicted to it. You cannot get dependent. However, let me say something that I hear all the time. Some of my patients come in and they say, I don't want to get addicted to Suboxone. Okay, we kind of have to take a step back and go, the only reason you would ever be given Suboxone is that you already have dependence to opioids. So let's establish that. You are already dependent on opioids. Otherwise, you don't qualify for the medication should not be given to you. And so the idea of addiction is there, and it's a brain disease. It is not a disease of the substance. Okay. And so that's why we don't look at it that way. And so there is no like trading one addiction for the other. If the person has the disease of addiction and there are those dopamine pathways and it's affecting the part of the brain and those things that might exist there through traumas and other things that kind of define what addiction is for that person, it's not about the drug as much as it is about the brain, although they're both intertwined. So these medications can be used in the case of buprenorphine. There's a injectable once a month. There's a sublingual under the tongue, daily dosing of either through strips or pills. And then there's also even some implants that can be done for 6 months called probufene. In the case of naltrexone, there's an injectable once a month called Vivitrol. And then there's an oral form, which you dose once a day. In the case of naltrexone, the tricky part, and this is when I'll end here, the tricky part about using naltrexone is that somebody has to be completely withdrawn already from the opioids. You cannot have a bunch of opioids sitting on your opioid receptors because it will put you in precipitated withdrawal. So that means that, days have to, depending on the substance, the version of the opioid that they've been on, have to pass before they can even kind of be put on that medication. So certainly ideal for places like residential treatments, if once they've gone through detox, if they're there for an extended period of time, that after a week or 10 days that they can be transitioned to something like naltrexone, ideal. But out in the world, when kind of everyone's left at their own devices and the struggles of just being around their environment that might not be, that might be toxic, it's kind of a tricky one to actually use. And that's why buprenorphine, it's, a little bit more accepted for those kind of situations, particularly for stabilization. Dr. Quick, did you want to add anything to any of the MAT discussion?
No, other than the other questions. I think that was a very thorough background on MAT. I will say I'll add something about what is evidence-based medicine and how does it apply to this, and then we can fill in anything that you'd like to about the other questions. I think, what is evidence-based medicine? Traditionally, we think of that as using basing clinical decisions on the best available evidence. And really what that means, I think in this case, is that for medication-assisted treatment, we do have very good clinical evidence for the efficacy of these medications in opiate use disorder specifically. So I think that it's important to note that when recommendations are made for individuals to be offered MAT for opiate use disorder, it's because we have good evidence for that. And evidence-based medicine across the board is ever evolving. So the other piece of this too is that it's a clinical decision between an individual and their healthcare provider. And really what we want is for those healthcare providers to be offering their patients the best available evidence and recommendations based on the studies that are least likely to have bias and all the other things that can be in medical practice that aren't necessarily factual. And then it's a discussion between the provider and that individual about what's best for them. So that's my take on that. And I'm happy to hear Dr. Mario's take on that as well.
Yeah, and I agree completely. I mean, I think you covered that well. I guess there's one other one here in the middle of who it's used for, and maybe I'll add a little bit to that. It's a medication that is used for somebody that has dependence to an opioid. Now, do you have to be dependent in the moment? Actually, no. So you can have, let's take an example. My patient Joe, fictitious name, and Joe he's been using heroin for 10 years straight, and for the last 2 months he's been doing everything he can to not use. So he's only been using maybe every third day, maybe every fourth day. So he doesn't really have lots of tolerance. He doesn't really have lots of dependence from the standpoint of what we mean from the physiologic aspect, because dependence is not the same as addiction. And when we look at addiction and we look at the DSM-5, the kind of the book that more or less figures out what we call something, a disorder of some sort. In the case of this disorder, there's all these other areas of your life. And for anybody that's involved in any recovery or 12-step or anything, I mean, you know this very well. People's lives begin to fall apart. The dimensions around work, around relationships, risk-taking behaviors, lots and lots of behaviors that, despite the negative consequences, they continue to do them in a compulsive fashion, and then continuing to drug seek and maybe use a lot of their time trying to get access to the chemicals. And oftentimes they don't even want to do it. They can, if they might have that aspect of this, the insight to say, I can't believe I'm doing this. And that's why we also say, you know what, don't get upset. Understand addiction, and you won't get upset at somebody that has addiction, because that's for my colleagues who we try to train. Folks like Dr. Quick and I are always trying to help our colleagues also understand addiction, because for a lot of docs and nurses and others that are involved in the healthcare industry, it can be a scary and frustrating group to work with, just like every group has to work, right? Some people don't like to work with babies. They're afraid of going in a neonatal intensive care unit. Other people don't want to work with older folks that don't hear well. I mean, take your pick. There's in my group of folks, it's behavioral, because addiction manifests often as a behavior. So, who it's used for, it's used for somebody that has dependence to an opioid, that has had all of these other consequences, that kind of meets that criteria. Though it can also, there's now evolving evidence to show that even in people that don't have addiction, that just have dependence, maybe they were being treated for chronic pain, but their doses of the chronic pain medication are so high now that they have other side effects, that in the using buprenorphine, it is probably one of the safest versions of any type of an opioid that exists, partly because, and I didn't mention this, but it has these special properties that make it kind of the superhero of opioids, in the sense that, like, in most cases, if you take higher and higher doses, you can stop breathing. I mean, that's a simplified way. It can cause respiratory depression as one of the side effects of an opioid. In fact, when people overdose, that's what happens. Now, it can happen from joining two chemicals that kind of both suppress the nervous system. But in the case of buprenorphine, it has what we call a ceiling effect. And that means that even if as high the dose gets higher and higher, it actually doesn't have that same correlation where your risk is equal. It actually levels off. So you're less likely to have even an accidental overdose from it. I already mentioned the part of the blocking. So even if somebody were to take another opioid on top of their buprenorphine, it's going to be blocking a bunch of that. And it's very long acting. So people don't have these ups and downs and ups and downs. So anybody that's ever used heroin or hydrocodone or anything like that knows that if you're dependent after about 4 hours, life's not real good anymore. And you're going to have to figure out how to not feel bad. And if we think of withdrawal, it actually makes a lot of sense. Withdrawal is very logical for a human being to want to not be in withdrawal and to do all sorts of things to get out of it because it's uncomfortable. And that's what we do. We get out of those situations. So useful for those folks. It's FDA approved for 16 and above. Has been used for people that are younger. We are seeing more and more, people that are impacted in the adolescent age, at a younger age. And really what we're after is harm reduction in many ways. And so if somebody who has been, using intravenous drugs, who's been using heroin, let's say, my buddy Joe here, for 10 years, and if for him to be on Suboxone means he doesn't inject a drug, now he's not at risk for hepatitis C, HIV, infections, MRSA, endocarditis. The list goes on and on. In just from the removing the injection use part, not to mention the death part that can come from the concentration and now what Dr. Quick mentioned before about fentanyl exposures and all these things that are out there. So that's an example of how it can reduce the risk for people. And then once stabilized, they can then engage in appropriate counseling and other things that they need to do, maybe program, maybe be in an IOP, maybe whatever it might be in the long term, until they are in a point where those other dimensions that were failing to work well are better. And then maybe or maybe not taper off of the medication. That's an individual choice. And one of the things I'll say is that I find it a little disturbing still to see that a lot of programs force some of the patients to come off of MAT or don't accept them. And that's maybe worth mentioning here. It's unfortunate, but I think it's changing that in a lot of settings, people that are on MAT that have taken that have taken control of their life and said, I'm going to get help, that there's a stigma. And so even when they go to mutual support groups, that somebody says, well, you're still using, usually it's not said that nice. Usually it's said like, you're still a junkie. I'll say that in air quotes and language I wouldn't want to use, but that's, that they're saying that you're still using. And so they're shunned from it. And a lot of times people show up to meetings and they just basically don't share that part. And that's an unfortunate thing because we want people to engage in that mutual support. They need that as well. So it's important that we talk about these and, hopefully you guys will have the kind of questions that we can, dispel some myths as well.
I have one more just follow-up point on who it is useful for, and wanted to make a point from the population standpoint. I believe, as do other, I'm not going to say everyone, as do other public health professionals, that the single most important aspect of population treatment for opiate use disorder is low barrier access to treatment. And that really includes access to MAT. So access to those medications, particularly buprenorphine, is like the single most important thing we can do to keep these folks alive and get their lives turned around. Also wanted to follow up with a point that the vast majority of people with opiate use disorder do not get MAT. And that may be an issue with access to care or stigma, but across the board, we are really struggling as a society to get people this treatment that is evidence-based. So to tie that back in, we know that this works for treatment of this disease, and we are not getting people into treatment for it. And that includes in Orange County.
Yeah, Dr. Quick, thank you for bringing that up. That's really our next question is, how does stigma impact access to evidence-based treatment for opioid and alcohol use disorder? What are the barriers? What are you hearing from patients? Where do you think we could do a better job?
Well, I think that in terms of, what part of what we're doing here right now is just education, just talking about it, I think is one of the most important things. to dispel some of the myths around medications in general. And, I think that one of the things that I've learned for sure, not just from my patients, but from kind of the body of science that's out there, is that there's no one approach to anything. And it shouldn't never be really painted like that. Certainly MAT is not for everybody. It can be important for certain people. But stigma is something that has existed against folks that have and that are affected by substance use disorders forever, right? It's been misunderstood as a moral weakness. It's been misconstrued as a criminal activity. It's been used against people. We've had to even create laws on privacy for that reason, and we still suffer from the ignorance that drives the stigma. And so, if you're somebody that happens to have a substance use issue, it can be easier to not say anything and to suffer the consequences than to go out there and feel like you're going to be judged. And maybe the perfect example of this would be a woman who is pregnant and using substances. We know the data shows that that group will show up to treatment the latest. By the time they get to prenatal care, they might be second, third trimester, in part because they've been doing gymnastics in their head about, oh my God, what am I going to do? What are they going to, because there's still a lot of folks, and not up until recently, that some of the states in the United States stopped trying to be punitive about having a medical condition. In other words, if you have the disease of addiction, you happen to get pregnant, why would you deserve to be jailed? Why would you deserve for your family to be broken up? Why, there needs to be more thought put into that. And so we are doing that, and we're trying to do that. And so stigma is one of those drivers that keeps people away from treatment. It keeps, folks from bringing it up to their doctor. And I'll say that in many ways, our own health system can perpetuate the stigma. And this is why, I mentioned that, folks like Dr. Quick and I spend a good chunk of our time even educating our own colleagues, because in medical school and other types of professional training, they don't necessarily spend a lot of time discussing the neurobiology of addiction and why it is something that should be, studied and treated just like if it were high blood pressure or anything else. So stigma, in my opinion, kills. And it's important for us to educate and put the information out there as much as possible.
I want to add that it's stigma, the stigma extends to providers as well, and it's twofold. Individual providers may not want to treat this in their practice for a whole host of reasons, one of which is stigma about these disorders and how they conceive of them in their life context and even their medical training. And it was in the not very distant past that providers were actually prosecuted, as in like criminally, for treating individuals with substance use disorders. And even now in some states, there are real fears that are warranted by providers about providing this service, as I would say, because buprenorphine, simply because it's an opioid. And so providers have real fears and stigma that prevents them from offering this as a treatment to their patients as well, which is something that, Dr. Mario spends a lot of time talking to people throughout the state on this. And it's very important, but it's important to note that this stigma is on all sides of sort of the medical profession, patients, providers, health systems, even the billing aspects of reimbursement. There's stigma that's there as well.
Thank you. I think that speaks to something you mentioned earlier, Dr. Quick, that you are seeing, or there's been a decline in the number of prescriptions for Suboxone since 2018. Do you attribute that to the stigma among providers or the concerns that they may have?
That's a complicated question to answer for Orange County. And I think there's some unique circumstances in Orange County that have to do with some of the reimbursement issues and some changes that happened in the county. But in general, yes, there are, the lack of adequate provider prescribing of buprenorphine, one of the elements of that absolutely is stigma. We will have providers that go through the training to become a waiver, get an ex-DEA waiver so that they're able to prescribe buprenorphine. And for a whole host of reasons, they never do that. But a lot of times there are system level change that is needed so that individual provider feels supported in their system, in their practice location, whatever their circumstances are, before they can actually start treating patients. And one element of that is stigma, for sure.
Great. Our next question is, what are the typical treatment goals of MAT for people with opioid use disorder? How do you identify a treatment plan for an individual patient?
That's a wonderful question, because I think that we can look at this in kind of two ways. There's kind of an addiction medicine provider, kind of trained person that might look at this really as what we call a biopsychosocial type of approach, where you're looking at really the whole person care. And I think that is the correct way to do it. And we are as an industry moving towards that more and more into integration into primary care. I mentioned to you before is that how we kind of make things a silo. We separate it out. It should not be separated out. It should be brought into the fold. It should be thought of in when we do screenings and when we do everything else. And so when we offer treatment, the goals should include the aspects of substance use disorders, but that's not the only thing. Right, because I mentioned to you before that there were a lot of comorbid or other things that complicate the situation. So when somebody comes in for treatment for MAT, I'm not just thinking about maybe the substance that they're on. In fact, I'm trying to get a sense of the person's whole experience in life. It could be that the most important thing to discuss at some point is something that happened to them when they were 4 years old and that has not left them, and that they have significant traumas. And that might be a focal point to discuss in the future as we do these other goals where we stabilize. I mentioned to you before that medications like buprenorphine stabilize. So if I have somebody that they're living in their car, they're injecting heroin or whatever, using whatever they can use. They're also using meth. They're using cannabis. When they run out, they're drinking alcohol. Again, because addiction is not a disease of the substance. It's of the brain. Any one of those things could be used at any point. The idea of somebody just using one thing is we don't see very frequently anymore. But my immediate thing is, how do I stabilize a person in that situation? How do I make sure to also address their housing, the social determinants of health, these issues that are affecting them? It's just in the same way that if you have somebody that let's pretend somebody has diabetes again, and they have an insulin pump, a little device that sits next to them that feeds them the insulin and checks their blood sugars. Well, good luck with that whole insulin pump if you have somebody that's in the midst of their disease using methamphetamine, let's say. Good luck with that insulin pump. Just in the same way that I would flip it around and say, you know what? You also have to address these other things in somebody's life in a very comprehensive way to help them be in a situation where recovery and stabilization can happen. And that might mean first getting them in a safe environment. That might be one of my first types of things that I'm thinking about. So I go from the most critical, which usually involves intoxication or withdrawal. Those are the first two things that kind of show up. And the American Society of Addiction Medicine even has these 6 dimensions of how we view addiction. Anybody here that is involved in the industry of addiction services, treatment services, you'll know the ASAM, right? The ASAM dimensions. And the first one is kind of there first, is because that is generally the most acute. But then follows medical issues, psychiatric issues around their own motivation to change, issues around their experience with relapses and kind of the progression of their illness, and then also their environment. So when we talk about goals, there are a lot of goals. First and foremost being that stabilization, getting a sense of what's worked for somebody, what hasn't worked for somebody. And then we might even have to be dealing with insurance issues and all these other things. There's a lot of different steps. we like to do screens. So many of you maybe have seen it. We do blood work and urine tests. And some of that is to screen for some of these things, because if you have hepatitis C, I would like to treat that so that you don't have a complication of cirrhosis later in life. If you happen to have chlamydia, I would like to treat that. If you know what I mean? These are simple things that there's a higher risk in certain groups that we will want to do to be complete. And then, of course, there's the connection and the coordination of somebody's care. I don't wear a cape and I don't have a big S on my chest. I'm just Dr. Mario. And there's a role for me in the team of what is the team to treat addiction. And then there's a lot of others that they have their own gifts and things that they bring to the table. An example of that would be somebody that's a peer support person, somebody with lived experience that brings to the table some training. They may be a KDAC. They may have had some training and experience and be able to help engage the patient in ways that I could never do. Now I have my own things that I can bring to the table too, right? There's the therapist. There's somebody that's a social worker. They all have a role in the totality of what is treatment to help somebody get more well over time in a chronic illness. So when we talk about treatment goals, I would say that my patients generally want stabilization right away. If they're withdrawing, right? They're withdrawing. They want make this go away now, if possible. And so we do that. And then after that, basically, we move to doing things that have to do with all of the other comorbid issues that might be around there, and then helping the person meet their goals, whether it's for abstinence or even reduction. I have had patients that tell me, you know what, doc, you could give me this whole Suboxone thing, but I'm not going to stop using the meth. So I don't not treat them. We will come up with our own treatment plan around this and say, well, how about this? How about we talk about reducing the amount you're using right now? And then we continue the education. And then I connect them with more services. And then somewhere along the line, hopefully, we're risk reducing and they don't bounce into or bump into fentanyl one day, for example. And that's that idea of that harm reduction.
So I'll just add one thought on this, and I completely agree with everything Dr. Mario said. And really, as a provider looking at a patient, it's similar to when it was in emergency medicine. What's the first thing? Well, you need to keep the patient alive, right? So it's that stabilization, making sure that the patient is going to live so that they can become an active participant back in their life. And I think one of the critical components that I'd like to stress with this is the treatment goals for the individual are individualized. So a treatment goal might be very different between two patients. And that's that relationship between the provider and the patient, and why that's so important, so that you can really make sure that that individual has a say in what their treatment goal is. For some people, that's to be stable on buprenorphine for the foreseeable future. For some people, that isn't what they want. And so it's very important to make sure that to understand, I should say, that it's an individualized treatment plan for that individual. I also think that it is critical to kind of make a comparison here to other chronic illnesses. So if you have somebody who has diabetes, what are your treatment goals of insulin, right? So it's getting that disease under control so that they can thrive in other areas of their life, as well as take care of other medical conditions and or avoid those medical complications. So there's a lot of things that go on with that Dr. Mario has already mentioned that are sort of co-occurring issues with our opiate use disorder patients, including other infectious diseases like hepatitis C or sexually transmitted infections that tend to occur in this population. So that is all part of the treatment course, but this is similar to other chronic diseases. And I think it's important for people to remember that.
And, one last thing that I'd be, I definitely want to make sure to toss in here is, if my patient allows me to, I want to engage the people around them, that they're their support system. They're the people that love them. It can be family, it can be others that are also in recovery, that can be a friend, it can be whoever, and helping risk reduce as well. So I'm going to teach them about naloxone. I'm going to teach them about Narcan. I'm going to teach them about how to use it if somebody were to be found, impaired or looking like they might have overdosed themselves. I want to prepare them for some of those things, and then also to help educate the family to understand the disease of addiction so that they can better engage with their loved one, because it can be, there's another journey that happens. There's the journey of the person that has the substance use issue, and then there's the journey of the people that love that person, and they're not the same. And they don't, and so there's, different issues around codependency, around anger, around resentments, and there's, similar tools that can be used, but they're not the same, and they're not appropriate to happen necessarily at the same time in the same room. But I start that process as well, because the recovery of my patient will also depend on this environmental issue.
Thank you both for that. So I want to just pose one last question. We're going to skip a question, and is meant for everyone. And then after that, we'll open it up for questions. So, are there folks that it's not appropriate for them, and why? And are there folks that it's more appropriate, and why?
I'll start off real briefly. And I would say certainly there are some people that for whatever reason don't respond well to the medication. For their tongue might swell. They have something physical that can happen from some of the constituents in the medication, and sometimes we have to change the formulation. So maybe we go from a strip to a tablet, or from a tablet to the injectable, whatever the situation is that they're having some issues. But I would say that for those that maybe they're not the best candidate for this medication, are ones that are experiencing such disorder in their life that even the flexibility of outpatient-based opioid treatment using medications, whether buprenorphine or Vivitrol, naltrexone, doesn't matter which one, that they need a higher level of care. So it's one of the nice things compared to, say, methadone, is that I could get, maybe in the beginning, I might see somebody once a week for a couple months, and we're going through our goals, we're doing whatever we're doing. And then they get stable. They're in maintenance. They're like, hey man, I got my job back. My wife's talking to me. Even my dog came and licked my face the other day. Things are looking up. I'm getting independent again. I like this, and I don't feel like crap every day. Like things are getting better. And so they're doing their thing in terms of their treatment. The medication's doing a piece of it to help stabilize them. But then some, if they don't have that kind of a response, and they're not able to, I might give that person a 1 month supply of their medication. But if I give a 1 month supply of medication to somebody and they use it all in one day, that's not the candidate for this flexibility. You kind of still have to be somewhat functional from that, aspect of things. And so for that kind of individual, either a higher level of care, either stepping over to something like methadone, where there's a daily dose, and then engagement with a team of people every time you show up, that they're eyeballing you, a nurse and peer support folks and others, or they need to be in a higher level of care, like a residential setting, other types of support. And I want to do that quick, because I don't want them to get arrested. Because that's, although I could tell you that in Orange County over the last few years under, wonderful leadership, there's been an implementation, folks like Dr. Chang, who have helped implement medication-assisted treatment into the jails. We've seen an extraordinary, magnificent, because across the nation, actually, for those that are implementing it, results of those folks that are in the reentry group, the folks that are coming out of incarcerated environments, out into the kind of the general society. They used to die at levels that were orders of magnitude above in the first 2 weeks coming out of the incarcerated setting, and now with Matt, they don't. And so but I still would rather them engage in treatment. And so if I can do that, I want to connect that person. So it is definitely not for everyone. There has to be some compliance. Also, they have to be open to the idea. So sometimes we'll see a 17-year-old, not 18, Mom and dad are there. Mom and dad might want them to do it, but they don't. Well, that's not a candidate for somebody. We don't force people into this. Is a completely voluntary type of situation. And so that's not the best patient. The other patient that's not is the patient that continuously shows that they are misusing the substance. And sometimes you just find that out, kind of they're strategically using the substances and you're kind of playing a cat and mouse game. But then you kind of have to ask them, so, well, what are your goals, Joe? What's going on here? It's the, you've relapsed every 2 days here for the last 3 months. What's going on? I'm working with you. We're doing all these extra things and you're not showing me, what do you want? And we may need a whole nother, again, a higher level of care, or we may need to be addressing other things like mental health issues that often can be ignored, that, you can't ignore those things. They have to be treated as well.
I would just really quickly add, and I know we want time for questions here. In my opinion, MAT should be offered to everyone who qualifies. And Dr. Mario gave a good overview of that earlier. And along with that, we need to ensure that there's low barrier access to MAT, right? So that means availability of clinicians and providers in geographic areas where these folks are, and offering services such as telemedicine for people who can't get into a clinic. So there's all those pieces of it that, need to be in place. And then there's the larger aspect of, there's of course the individual choice and the criteria that Dr. Mario just outlined of who's a good candidate for it. And that's really between the individual and the provider. But as a system or a county or a nation, got to offer it where it's needed and make sure that that takes place, and also make sure that all of the supporting services that surround this really are accepting of those who are on MAT. And so that's another piece of this as well. It's like medication for other chronic diseases and needs to be treated that way.
I think it's an appropriate time to mention, both you and Dr. Mario see patients at KCS. And KCS has been doing MAT in the community probably longer than any other clinic. And I want to thank Ellen Ahn, the CEO of KCS, for allowing both Dr. Mario and Dr. Quick to speak here today. I think she's done an outstanding job of really building exactly what you said, Dr. Quick, low barrier access. And that's the goal of the MAT Connect program, is to ensure that everyone can access it through a community health center. Those folks that are insured, those folks that are uninsured, they will be seen regardless of insurance status or documentation status. And so that's, why we're here today, in part, is really to just provide the knowledge to the community that we are available, we being all of the MAT providers in these various clinics. So thank you to Ellen and for both of you being here. So at this point, are there any questions? I think that we can unmute you, or you can unmute yourself, Rhiannon, and how will that work? Do you want them to put all questions in the chat, or I'd prefer folks be able to unmute themselves and ask the questions?
Yeah, I think we can do that in a relatively orderly fashion. Just go ahead and use the reaction hand raise, much like I'm doing right now, if you have a question, and we'll tell you to jump off mute. Or if it's easier, just feel free to jump off mute and ask your question, or drop it in the chat box.
While we're waiting for someone to be brave enough, I will ask a question. So, Dr. Mario, I know that you and I have talked about the plan of safe care, and there is a movement in Orange County to create this document that a pregnant woman can take to the hospital for delivery that really is designed to let the hospital know that she has a plan in place, that the child will be safe in her care. And in some cases, the hospital, if they feel comfortable and confident that the mother is in treatment, and if the baby tests substance exposed, that she can retain custody. Can you talk a little bit about that?
Sure. So, what Julie's talking about really stems back to two federal laws that were revised around 2016. And what they did is they called, one that kind of deals with addiction, and the other one with abuse and child welfare. And what they did was they kind of said, we're gonna kind of give you a little bit more guidance, states, on what you're going to report and then also what we're gonna do for people in this very vulnerable situation. Because the outcome of if you create the consequences and the stigma so high that people hide, guess what's waiting for you after delivery? You're going to have a lifelong potential damage to a child, because of somebody that's hiding from the fear of being prosecuted or whatnot. So, but nevertheless, we need to have a system that protects the child too. So it actually came a bit from that, is where we needed to figure out, what are we going to do once we identify and screen that there's a woman who's pregnant who has a substance use issue. And, again, we talked about lots of opinions about that and about social services, but we are trying to kind of come together and have some sort of a consensus. Well, what do we do with urine drug testing? What constitutes abuse versus somebody that has a disease that needs to be treated and that their family could stay together. So obviously the first kind of the overall or overarching goal among social services is that families stay together. Now, with that said, you want it to be safe, right? It has to be safe, a type of environment. But so this plan of safe care really is an opportunity for multiple agencies, or even the healthcare provider, as well as others that are involved, to add to what that plan of action is going to be for that woman who is experiencing substance use, and that infant who is being exposed. And the way it works is actually there needs to be one is the evidence of the exposure. So let's say that happens at delivery, that there's a positive drug screen, and then the baby might have signs of some sort of withdrawal or other consequences. And then generally there's the idea that there's other indicators, like a risk of some sort. You have to have both of them to meet criteria for when you report it, really that kind of can rise to the level of something that is, now needs to be further investigated and assessed, and there's case managers involved. And then, then it may or may not be something that's considered to be something of abuse, but it is by itself, say a woman who has a positive drug screen, that does not constitute abuse. Okay, that's kind of important. And then the role of the healthcare provider as kind of mandated reporters or whatnot. Again, you have to look at those circumstances and be very careful, actually, as well, about how drug screens are used, because if you don't understand drug screens, and a lot of people think they understand them, but one of the things that I do on the side is I'm an MRO, a medical review officer. It's kind of the geek doctor that likes drug testing stuff. And so there's an entire subspecialty, because there's so much in that world of false positives, false negatives. There's all these things in there that, in the case of a situation where Child Protective Services or anything, or any other social services are involved, if you get results that are not accurate, you can change the course of an entire family. And of course, the goal is not to have all the kids in foster care. But what we do see is that, over the last decade, the reason for separating families and putting kids in foster care has been increasingly this idea of drugs being involved. And that's been going up and up and up. So this plan of safe care is supposed to be a way to be able to have some sort of a plan, not just medical and obstetric, but also, parent classes, addressing mental health, housing issues, whatever the situation is for the plan. And so that way, when she goes to the hospital to deliver and hands somebody this document, that people can see that this has already been addressed. It's there's an effort to be healthy, to address the situation. And then if it goes to court and whatever, then that information can be used. And oftentimes it can be the difference. Like a woman in MAT who is pregnant, and there's a kind of some sort of a plan of safe care, has a much higher likelihood of keeping her family together and of doing what needs to be done, versus somebody that just kind of shows up without any sort of a plan. And that's kind of where that comes from. And that is, again, it's a federal type of thing, and every state can do it, their own way, but there's some certain principles. And my understanding is that there's actually going to be a whole nother form, a document that comes out in the next week or two. That's a rewrite of some of the ones that exist now that can be used in any office.
Clayton has a question. Clayton, you want to ask your question?
Absolutely. First and foremost, thank you so much, Dr. Mario and Dr. Quick, for doing this town hall. Appreciate it. All the information you guys are giving is awesome. I'm glad you mentioned the different components, almost like a holistic approach. I'm thinking most specifically in regards to patient care coordinators, peer support specialists, etc. How do you, what kind of advice would you give to those staff members who maybe are engaging with possible MAT patients or doing outreach in order to advocate for MAT? Because we don't have that, medical degree background, it might not have as an impact, falling on their ears as it would come from a provider. What kind of feedback would you have for possibly like peer support or patient care coordinator?
Well, I don't know if I'd agree that you didn't have the impact. To be honest with you, that person is often way more listened to than me. It's easy to get tired of hearing me say something. Just ask my wife. But it's more of one of those things that engagement, it can mean a lot. So I would say number one is to just to be very, you don't need to be clinical. You don't need to provide statistics. You don't need to show graphs. I would say to be objective about it. The fact is that there is evidence for this. It is an individual thing. They should not fear asking questions or going in for MAT. You clarify the myths, know those myths that exist out there, not in a medical way, but in the way that's for, the treatment. That is so strong, so potent. And because when you normalize it and it comes from somebody like a peer support or a case manager or somebody in that's kind of the social side, it also reduces the stigma directly with that patient. And that's priceless.
I was just going to add on that, and I completely agree. Having worked at various clinics throughout my career, treating opiate use disorder or just substance use disorder in general, having all of your staff have a basic understanding of what it is you're trying to do and ways to talk to these patients. And the stigma piece is huge because a lot of these individuals have gone through many years or even almost a lifetime of really not feeling accepted or able to be their true selves or be honest with their providers or whatever it is. And so having an organization and all of your staff have that sort of perspective on how to treat this population is huge. And so being aware of the stigma and ways to address that, I think is critical and really helps with retention and getting these folks to the place that they need to be.
Another role for that same group is within the organization you work in. So we have a large, there's a heterogeneity in the county between, IOPs, PHPs, residential treatment, detox centers, outpatient clinics. They do things differently, and there's a different culture in each of them. And where somebody bumps into can make all the difference actually in their life. So if you might be the sound in the singular sound in an entire organization that says, you know what, abstinence only can be good for some people, and maybe not everybody. MAT can be good for some people, maybe not everybody, but everybody should know the options. And then we need to be able to offer the options. And if we don't offer the options, we should be able to connect them to somebody that offers the option if that's what they choose in their life, in their situation, in their circumstance. And so that's another area that's, I think, another important thing. We're seeing an evolution of that, I think, over time.
Thank you both so much for your answers. Honestly, just being the MAT champion for your clinic makes so much sense. And you could be anybody from a peer support to patient care coordinator. Thank you so much.
Great.
It looks like Stephanie has a question in the chat. The question is, what systems or structure is in place at KCS for patients to receive services as quickly as possible?
You want to take that, Dr. Quick, or you?
Why don't you start from your perspective? Because I think you experience it firsthand, and I'll add some.
So I'll tell you the practical part. The practical part is, I kind of lead the services effort at KCS. So I am the bottom line from the standpoint of access. So my policy is that everybody that needs to be seen should be seen the day they need to be seen, immediately. And even if that means calling me and I see them at 7 p.m. at the end of the day. And I've done that. I did that last week. Okay. I did it last week at the end of a long clinic. Jewel sends me a text message saying, hey, there's this guy. And, I said, okay, well, let me talk to him afterwards. So access, and that wasn't even a formal visit, but it's to set it up for the formal visit, which we did, I think, the next day. But so, that's kind of like on the practical side is we want to get people in pretty much immediately if possible. There are some details, right? We have to have them fill out some paperwork. We have to assess whether they're appropriate. So there are assessments that need to be done. But I'm very aware that if that person happens to need stabilization, like we discussed earlier, I want to do that as quickly as possible. I just don't want to do it with no information, but we can generally do that very quick. And I'm not the only provider. We have a wonderful team of folks, that are also ex-waivered, Dr. Quick, Dr. Vincent. We have a team of nurse practitioners who have extensive experience now. They've had additional training, all in substance use disorders and MAT, that also provide services. And so, there's also all of that army of folks that we're trying to make sure to address things as quickly as possible and to be comprehensive. So that's how it is for KCS right now. And there's even stuff online that you can actually print out and fill out and just email in.
And I'll add a little bit on just the structure and logistics of it. As Dr. Mario mentioned, I think one of the critical components is ensuring that there's adequate staffing. And Dr. Mario has trained our nurse practitioners to the point where they are probably better trained than a lot of other physicians who have gone through waiver training. And essentially what is required to get people in is exactly that. You have to have providers available for when these folks either call or walk in the front door or they're released from jail. So that training and staffing is critical. And that really requires support of the entire organization that you're working at. So luckily at KCS, we have Ellen and Anna who are very involved in this and supportive of taking extra time to train up all of our providers so that we're ready to do this. And the other piece at KCS that has is a part of this that's just logistics and just a lot of work to get it set up is that a lot of our folks are doing in-reach both into the jail as well as some other places to make sure that those connections exist ahead of time. So when those patients come out, they're ready to go and know where they're going. So that's a piece of building the system of care so these folks know where to go. That's critical so that when they're in their time of need or between transitions and being released from the jail, that they know where their provider is and that we're ready to see them. And once again, critical, all the staff surrounding the providers. So the care coordinators, the medical assistants, the front desk staff, everybody has to be on board with what this looks like so that when an individual walks in or calls, you know what to do. And that's a lot of work. But once the systems are in place, we really are able to get people seen quickly.
It's worth mentioning that this concept, and I'll just toss it out there, give a quick description, is that, KCS is what we would consider a low threshold clinic. Okay. And that kind of maybe the easiest way to understand that is access is super important to us. So we want to have the least number of barriers, whether they're process barriers, social barriers, insurance barriers, whatever kind of barriers that are out there. Around at all that gets in the way of, two people communicating and figuring out a treatment plan. And it's not always Matt's not always appropriate or indicated. Maybe it's something else. But at the end of the day, we have the time where the two people are, again, engaging to have that discussion and figuring out what is an appropriate way to go. And sometimes that needs to happen quickly. So low threshold.
I also want to throw out one thing because it occurred to me, and I think it's important to note this. KCS has taken advantage of some of the I would say newer, it's not even newer, but the more widely adopted telehealth platforms to really help bridge this gap too and bring together patients and providers that historically we might not have been able to. So that's another piece of this, is being innovative and how you connect with those patients and what that looks like, which is changing in part due to COVID. And so that's another thing that I think has been successful in bringing this program together as well.
Absolutely. Who would have thought there's a silver lining to COVID? I think that is the only one. Della is asking a question. Is there a risk with MAT and breast milk for a breastfeeding mother?
It's perfectly safe to breastfeed on MAT, and we encourage it.
I will second that. Absolutely encouraged and should be done.
I've had this question asked so many times, and what I think it is thank you, Jewel. Thank you, Dr. Quick. Thank you, Dr. Mario. I'm so grateful that so many people are on this call and we're all getting the message at the same time. The reason I get this question, I think, is a bigger question that you answered with Clayton. And that's that there's angst, it's a change. And here you'll have a mother who's using benzodiazepines, or she's using heroin, and her concern is with a medication-assisted treatment program affecting her breast milk. So I think what you said, Dr. Mario and Dr. Quick, really resonates. The fact that everybody would be on the same page from the moment the person walks through the door or logs on to their telehealth appointment. And that page is comforting, that is being the MAT champion, and come on in, we're ready, willing, and able to help. In other words, I guess what I'm trying to say is that I hear this as an excuse on a pretty regular basis. And so thank you for answering my question way back with Clayton by talking about MAT champions. And thank you so much for being here.
I had sort of a follow-up question to what was asked earlier, and in terms of low barrier access in comparison to something like a methadone clinic, and just considering, like, with folks I've worked with in the past, folks who say, you know, I'm ready for treatment if there was just a place I could go now, if there's just a place I could go now, what would be like pros and cons or a landscape for a clinic to offer buprenorphine or Suboxone on more of a like an immediate basis for someone whose prescription has ran out, or they're ready but they can't have a doctor's appointment for 2 weeks? Has that ever been thought through, or is that just wild dreaming?
No, I mean, that's generally that's an internal process for each clinic, really. You know, and we've talked about that. I mean, we have a structure, for example, at KCS, where each of the providers that is trained to provide MAT services has a medical assistant that they work with, that they, you know, basically they have their own synergy, and they get to know their patients. And when things come in, we even try to advocate for the patients. So one of the things that we didn't talk about here, but maybe worth mentioning, is if you provide MAT services, you generally have to be pretty motivated, because even for the provider, there's actually a lot of barriers. And one of the barriers is a lot of places, pharmacies, don't carry the medication magically. They'll carry other medications, or they ran out that day, or they didn't treat my patient very nice and got an outburst. There's so many different things that can happen that involve the pharmacy side, and it's a multifactorial problem. It's happening nationally. Some of it involves kind of DEA level stuff, and some of it involves wholesaler stuff, and being kind of flagged, or fear of being of dispensing too many controlled substances, or even the concept that in society we still view things like oxycodone prescriptions the same as buprenorphine. So we've created a system where it's as difficult or not or more difficult actually to get a prescription filled for the medicine that's used to treat opioid use disorder than the medications that oftentimes were linked to the problem in the first place with prescription drugs. So internally, we try to advocate for that. So, if you know your patient and you have to have the kind of policies and procedures internally, our version of that low barrier is like, for example, somebody runs out, let's say they relapsed. Well, guess what happens in addictive disorders? People relapse. It happens. And so let's say let's say something else. Hey, doc, somebody stole my backpack. I had all my Suboxone in there. Okay. Whether it's legit or not legit, I'm going to need to deal with the situation. So I might have my own system. For example, I might say, well, I'll see them in 2 days. I'm going to give them 2 days worth of medication. I'm going to send it to the pharmacy, and then we're going to discuss the situation. We're going to do drug testing. We're going to do whatever interventions that we need to do to keep the person safe, but we address it at that moment. And that would be a proper way to be responsive to patients, which is no different than if somebody ran out of their insulin. I mean, what happens? You call the doctor's office, you leave a message, or you talk to their medical assistant or whatever, the nurse, and then the doctor's supposed to be responsive. So that clinic is supposed to be responsive, no matter what medication we're talking about. And in the case of substance use and MAT, I think it's as important. So there should be no link. So that's an internal thing. And I hope, I try to be the example by saying it needs to be important to you, to my colleagues, and to the clinics. You need to create systems that favor the patient, not the convenience of the provider.
I'll add one very tangible, sort of follow up at what we've done at KCS. We in general do not take phone calls after hours for medication refills or medication issues. Certainly if a patient has like a drug reaction and needs to talk to a after hours provider, we're going to respond to that. But in general, if someone's run out of their medication or wants a refill, that is a during business hours sort of response. But we have ensured that our after hours service for our patients who are on MAT at KCS, that they can reach a provider after hours for these issues. And they come up all the time with pharmacies and prescriptions with these medications. And so that's something that we have in place because we recognize that it's important and these individuals deserve that sort of response.
Here's another question in the chat. And I know I get asked this question a lot when I talk about MAT. It says, when a client has been stable and in maintenance, when would it be appropriate to taper them off Suboxone? What if the patient has been on Suboxone long-term and does not want to taper off? What would that be appropriate? Is the purpose of Suboxone to taper off? What are your thoughts?
That's a great question. So the skinny on that, the short answer is it depends. Because just like what Dr. Quick had mentioned before, these are individualized circumstances. So I wouldn't say that, Suboxone, is not designed for, here's what doesn't work. The quick in and out, kind of like you put somebody on Suboxone and a week later you stop them. You haven't done them any favors. So in general, somebody does need several months to be able to get those other kind of things and dimensions in their life in better order. Some people decide to stay on it more long term. They treat it like they would a blood pressure medicine. So let's say you take a blood pressure medicine and you don't get headaches anymore. Your blood pressure is stable, and as a consequence, your kidneys are more protected. Your heart is more protected. The likelihood of you having a heart attack and a stroke is improved. So you take your one pill of a metoprolol once a day. Okay. So now imagine if I come in and go, well, when are you going to get off the metoprolol? And you're going to say, well, why would I want to get off the metoprolol? And say, well, you can't be on a drug all your life. Well, why not if it's doing these things for me and there's no other, side effect to it that would mean that I'm being harmed. So that's where part of the discussion is a chronic disease. So for some people, they believe that it's helping them and it's showing in their abstinence from, risky behaviors and other substances. And for them, it could be lifelong, years long, whatever they choose. Others they might reach a point, and I have all of these patients at the same time, they might reach that point where they're like, okay, look, I've been on the medication now for about a year. Again, we're back to the, my wife's talking to me. I got my job back. I've been promoted. My dog licked my face. Okay. Life's getting much, much better. And they have a community of support around them, and they're going to NA, and they've been doing wonderful. And they feel now that they would like to get off for whatever reason. Really, this is the choice of the patient. Okay. I support no matter what they want, but I give the kind of my spiel about whatever the risks are. And also kind of in assessing their individual situation, because we also get patients that like, they've been on it on and off for a year. They just relapsed 2 weeks ago. And then they're like, you know what? I think I'm cool. I don't want to be on the medication anymore. And then you look back, okay, before they started the medicine, they had 3 overdoses. They had to be Narcan twice. They got Hep C, and then they were in jail. And you go, okay, we don't have any of those things right now. And you're not, being fully and you just relapsed a couple of weeks ago. I'm going to still let them know, probably not the best of situations in yours. And these are the reasons why, these are some of the things we can continue to work on. I'm still going to respect that they want that. And I'm still going to walk them through what would be a taper. Generally tapers that last, longer over weeks and months are more successful than ones that are done abruptly, like a 5-day taper that you would see at an average kind of detox center, where you're kind of putting somebody in a restricted environment and, might cost $10,000 to do and that kind of thing. Not everyone has access to that, but you can certainly taper it slowly. And then, at the end, when the buprenorphine has a little tricky thing to it. At the very end, between 0 and 2 milligrams, that can be responsible for about 40% of the effect of the whole chemical. So that means that to go from like 24 milligrams to 12 might be easier than going from 2 to 0. So sometimes people need support, like certain medications, to help offset the side effect for nausea, vomiting, diarrhea. What is withdrawal from opioids? Nausea, vomiting, diarrhea, panic attacks, goosebumps, insomnia, stomach cramps, leg cramps, restless legs. There's a lot of stuff that's not fun, right? Your nose runs, your eyes, anything that can leak will leak from your body. And so there's medications that can help with some of those, but you can't cover the sun with one finger. They're not going to take everything away. And so some people, depending on their experience and withdrawal, handle it better than others. And it's difficult to predict. I've had some patients that are like, hey, that was a breeze, no big deal. I did it. And then other people that, 2 hours into them feeling any withdrawal, they're like, I don't want this anymore. I just want my dose back. So, back to the question, it's not meant to be any one of those things. It's individualized. And so just like any other medication, if it's working and it's not causing you negative side effects, then it should be used for the intention. If the risk to benefit balancing act is appropriate, like not dying, not injecting, not getting those other conditions versus taking a strip under your tongue. Where we get caught up is in this idea of, you're taking a substance, and some people have opinions about that. Even for mental health issues. One thing that we should say is that in the case of buprenorphine, it is not particularly euphorogenic, which means it's not really good at getting anybody high. So therefore that's a property that's an important one, because you get to feel normal versus getting high. So even from that standpoint, in terms of reinforcement, you're not reinforcing that aspect of things. Dr. Quick, you want to add anything to that whole?
Other than I just completely agree. It's individualized. And for some folks, that means they're going to be better off on it for the foreseeable future with no end in sight.
Well, thank you both for this time today. I think it's been very informative. I appreciate the opportunity that people had to ask their questions. I put my email address and cell phone number in the chat. You have information here about KCS. Please reach out to me or to anyone at KCS. They have an outstanding staff and will do anything possible to help a patient. You can see the dedication of both Dr. Nichole and Dr. Quick and Dr. Mario to the patient population. And so I can't recommend either of them enough. And thank you both for everything that you do for the community. All right, I want to respect folks' time. Dr. Mario put his email in the chat. Please reach out to any of us. Thank you so much, everyone, for joining. We appreciate it. All right, everyone, take care.